Well, I would like to welcome everyone in the IFEM family who has joined us for this very important webinar related to the COVID-19 pandemic. My name is Dr. Eddie Lang, and I am the co-chair of the IFEM task force on ED crowding and access block, along with Dr. Kim Hansen from Brisbane, Australia, and Arshia Javidan, who is the project coordinator and a medical student in Toronto. Our task force has been hard at work for the last several months, creating a comprehensive report to address issues related to capacity and optimal means of managing crowded emergency departments. And it struck us as we got together in one of our regular meetings that it would be important for our group to weigh in on the COVID-19 pandemic and the impact that it can have on both our emergency care providers as well as our emergency care systems. So as you may be aware, we ran this webinar a little over a week ago with contributions from Australia and from North America, and felt it was very important to run it a second time and get some additional perspectives. And in that regard, we're very fortunate today to be joined by a number of international emergency medicine leaders who you may know well. I'll do a quick introduction. We have Dr. Catherine Henderson, who's the president of the Royal College of Emergency Medicine, Dr. Colin Graham, professor of emergency medicine at the Chinese Hospital of Hong Kong, and Dr. Saravana Kumar, who's joining us from India, who's in a prominent emergency medicine leadership role. We're also very thankful to once again welcome back Dr. James Ducharme, who is the president of the International Federation of Emergency Medicine. So thank you for joining us. Our primary objective is to present the critical guidance document, which is available on the IFEM website, and to walk through this panel providing unique perspective on some of these issues as they might relate to the countries that are being presented. So Arsha, if we could move forward to the next slide, or Aaron. I just want to do a quick thank you to our technical support that we received from the Physician Learning Program at the University of Calgary that allows this webinar to proceed. And just one more quick introduction. Dr. Huma Ali will be speaking shortly on the wellness issue as it relates to the impact of COVID-19 on our physician and to some degree our nursing colleagues. So this slide was presented at the last webinar with some starkly different numbers. Anyone who's following this would be aware that we now have nearly 200 countries affected by COVID, 1.4 million confirmed cases, and sadly, quite a significant mortality toll of 75,000. And one of the worries that we all share is the degree to which the interface between the emergency medicine resources that a country has and the impact that that COVID will have on that population and on that care. Next slide. So I want to take a moment to recognize one of the stark realities of COVID-19, which is the impact that it has had on our healthcare provider and physician colleagues. We know that well over 60 physicians in Italy have succumbed to COVID infection. Now that the United States is in the heart of the pandemic, we are seeing colleagues from a variety of specialties in the United States falling to the disease because it's very much being a healthcare provider is very much a risk factor for not only infection, but for very serious infection. So I'd like to take a moment just to pause and think about the toll of this disease on our emergency medicine family around the world. Thank you. So Arshia, I'm going to pass things over to you. Dr. Arshia will be moderating this session, and we'll covering the 8 core topics, reviewing quickly the 8 core topics that we'll be covering today.
Thank you, Dr. Lang. So the 8 core topics that the task force will be addressing this morning is as follows. So measures that we recommend to limit transmission of COVID-19, ensuring that frontline providers have adequate access to PPE, and where PPE isn't available, having PPE alternatives, exploring the role that vulnerable clinicians and vulnerable populations have in the pandemic, looking at hospital capacity and how to create and preserve it, and also examining ED functional redesign. And then the last 2 recommendations that we'll be looking at look at the deployment of all healthcare providers, including the role of learners, as well as the role of palliative care. Before we dive into the recommendations, Dr. Huma Ali, an emergency physician in Calgary and the lead of the Emergency Physician Wellness Hub there, has an important message regarding the role of wellness in the pandemic.
Thank you very much, Arsha. As Arsha introduced, I'm an emergency physician in Calgary. So I want to talk a little bit about physician wellness during this pandemic. So this pandemic is a complex and chaotic time. There's many pieces to this challenge that are interrelated and directly influence one another. Emergency physician wellness is a critical part of effectively addressing this pandemic. Next slide, please. So as frontline care providers, we can experience increased work demands and stress, fears and anxieties with regards to personal safety and the safety of our family, concerns about having to make difficult ethical decisions in a resource-constrained environment, difficulty with sleep and concentration, increased alcohol and drug use, dehydration and fatigue as a result of wearing PPE, and this is not even an exhaustive list. So what can help an emergency physician? Things like staying informed from reputable sources, taking breaks from technology to avoid information overload, exercise, accepting that many aspects of this are out of our control, grounding techniques like breathing exercises, anticipating and planning for stress reactions, for example, recognizing when you're exhibiting signs of stress and seeking support, and having a plan in place if you need to self-isolate from your family. However, we cannot solely leave physician well-being in the hands of the frontline care providers themselves. That raises the question, what are some methods for leadership to acknowledge the impact on our physicians and support them? And the answer to that is system-level changes are important. Leadership must acknowledge the mental distress emergency physicians are feeling and incorporate supports into our current system. So I'm going to discuss some of the ways to do that. So one of the suggestions are to create a welcome space for a physician wellness representative at the decision-making table. Another way is to establish a support system where emergency physicians can reach out to their peers or have peers reach out to them after being involved in a COVID intubation or when on isolation or quarantine. Another way to make system-level changes is to create an emergency physician wellness group, similar to what we have in Calgary. And this is made up of emergency physicians. And this group initiates grassroots efforts to improve the morale of the department, such as through organizing online get-togethers and other methods of connection, such as text messaging, phone calls, care packages, etc. Something else that's very important is that we've organized for community help. So our medical students have actually offered to provide childcare for our physicians. Lastly, I wanted to bring up the idea of establishing a plan for how to support our emergency physician group if a physician becomes critically ill, dies, or commits suicide. So I've shared examples of ways leadership can institute change to support our emergency physicians during this extremely challenging time. The idea here is that system level initiatives are really the key. Lastly, as frontline providers in this COVID pandemic, emergency physicians need to feel supported, especially from a mental health perspective, in order to provide the best care to our patients and to work effectively. Thank you.
Great, well, thank you, Huma. We're going to move along in the discussion and really try to focus in on how different countries are going to be impacted both by the public health measures as well as the emergency department impact of COVID-19. I think we can move on to our very first topic, which is about the aggressive measures to limit transmission as one of the key opportunities in reducing the effect. And I think it's really critical for emergency providers to realize how important a role they can play in advocating for this. I know that you, as emergency physicians, you are all multitaskers, so I will let you review these bullet points on the slide, but most importantly, I would like to turn the microphone over first to Dr. Kumar and then to Dr. Graham to talk about how the physical distancing and public health measures have occurred in both of their settings to provide some insight. Dr. Kumar, you're on mute. Yeah.
Yeah, thank you so much. Yeah. So clearly, India has reported so far about 5,200 cases and 150 of them unfortunately didn't survive. So we have to take these numbers a little more with a pinch of salt, because are we testing enough is a big question which we all have in mind. Clearly, social distancing and lockdown, which I think India is in fact quite early in doing so before any other country. So this has definitely helped. At this point in time, not many of our emergency departments have seen any surge of patients at all in COVID, right? It looks like most of the emergency departments have handled so far about 5 to 10 COVID patients across the country. So this social distancing measure has definitely proven beneficial for a country like India, where 1.3 billion people. So just a matter of time, we might have an explosion of cases. So clearly, social distancing and public use of masks are the two significant the behavior changes which has helped control cases in India.
Thank you, Dr. Kumar. Dr. Graham, Hong Kong boasts one of the best records in terms of controlling the pandemic. Would you be able to share the strategies that you think are most important?
Sure, thank you, Eddie. I hope everyone can hear me okay. Hong Kong's been very successful so far. We've, thankfully, and long may it continue, as of today, we've had 961 positive cases out of a population of 7.5 million people. And that's been since really the middle of January when we had our first case. I think, as Dr. Kumar has already said, I mean, social distancing has been a huge tool for us. Hong Kong closed down its schooling very early in the epidemic, primary and secondary schools, and indeed universities have had no students and no face-to-face teaching since the very beginning. There was a period just after the Lunar New Year, so the end of January, where people were encouraged to work from home, and that was clearly very successful. There was then a short period where those restrictions were relaxed a bit and the numbers did go up slightly, and that has now gone back to encouraging as many people as possible to work from home rather than travelling on our very congested public transport system. In terms of the healthcare response though, we admit and isolate and trace all close contacts for every positive case.
The impact of delayed?
We're certainly admitting and testing and admitting any positive cases, and they're kept in hospital until their viral infectivity is cleared. So we've also seen in the last few days, or the last week or two, we have, the Hong Kong government has closed most social events, pubs, restaurants. Well, they haven't closed restaurants, but they've reduced the capacity by 50%. And again, all forms of trying to improve the social distancing techniques that we're seeing more widely now. It goes without saying that Hong Kong, having suffered SARS, everyone wears a mask. Everyone wears a mask all the time. I have to say, I was the biggest cynic on earth about the effectiveness of wearing masks in an outbreak. I have to say I'm completely converted now. does, to my mind, seem to make a significant difference. But and part of the reason I say that is our flu season ended spectacularly early this year. And I think it was the combination of social distancing, wearing masks, and hand hygiene amongst the population that made the difference. I'll stop there and see what feedback you've got.
Thank you, Dr. Graham. Are you able to hear me? So does anybody else want to weigh in on this topic before we move to topic number 2? Okay, perhaps we can move forward then. We are very fortunate to have Dr. Lori Mazurek joining us. Lori, are you on the line?
I am. Thanks,
Dr. Mazurek
Eddie.
is a world expert in questions of personal protective equipment, maintaining adequate stock, and other mechanisms to preserve equipment that's critical at this time. I'll turn the microphone over to her to speak to PPE issues, maybe with a particular attention to low and middle income country perspectives.
Yeah, thanks, Eddie. So what's on that slide is more or less what we discussed last week. So what I think I'll do is try to take us to an updated position of what's happening. I think finally, and it may not be globally, this situation the same everywhere, hospitals are revealing their actual burn rates and when they expect their PPE to run out. I'm sure they've actually known this for quite some time, but it's only now it seems to be that we are getting, as Frontline's getting some indication as to what our burn rates are and when we're expected to run out of PPE. What's lagging is the plan to, I mean, everybody is now using whatever PPE they have for as long as they can. So whether it's a surgical mask or an N95, depending on what the procedure is that you're doing, you are wearing it for as long as possible on your shift and only changing if it is degraded, so it's become wet or contaminated and you feel that it's unsafe to continue wearing it, then you change it. So I think everybody has adopted that. Most people have tried to move to washable gowns, and gloves have not turned out to be an issue, at least not so far. What's happening though is there are some black market products coming on or onto become available. You know, countries that are desperate may purchase products that may be below standard. Local manufacturing is kicking up. A lot of governments are sort of invoking almost war measures, sort of activities in directing manufacturers that may not be normally making masks to make masks and ventilators, and then the whole process of inspection and determining whether their standard is up to snuff is what may be the next risk for us. But almost for sure, whatever they create is going to be better than a DIY, at least I hope it is. In Canada, I can tell you that we are now making our own masks. The approval rate for that previously was 3 to 6 months. Our supply in many places is 2 to 3 weeks. So they've shorten the approval of these masks, and exactly what that means I'm not sure, but to 7 to 10 days. So many governments are doing that. It tells you that probably there are going to be products available, the quality of which people need to make sure they inspect it. I do know that some products were brought in quickly and for nursing homes here locally and found to be below standard, so they were sort of falling apart. So that's it's both a good thing and a bad thing. You just have to be aware that when you do rushed things that the standard may be something that you have to monitor very closely, and how you do that is a work in progress as well. The reuse in general, the reuse of N95s in particular, I don't think anybody's reusing a surgical mask, but the reuse of N95s, both the University of Manitoba in Canada has come up with a method, and Stanford has a method too as well, where they feel that they can reuse these masks by heat treating them, and that they would be good for maybe up to 10 more uses, which if you think about it, if you have a 3-week supply, that's 10 times 3 weeks, so that's 30 weeks, that could be significant. Who's going to carry out that reuse or heating process is yet to be sort of clearly defined. I mean, if I was going to do it personally, I don't want somebody else's mask that's been reheated. I'll take mine and do the process, and they are DIY types of procedures where you actually put them in your oven for a certain period of time. 3M, who is the major mask maker in the world, however, does not stand by these methods, but I don't know if that's just them just saying they don't approve it for whatever reason, because they never have recommended these things to be reused or to be treated in a way that can be reused. So they're probably not in a position to support that or endorse that. However, these are universities of good reputation that have confirmed that they feel that the standards and the integrity of the masks are maintained by these processes, and you can do it more than once. And so I think it's definitely worth everybody looking at their infection protection and control, or infection prevention and control teams need to look at this. It isn't something that you should be lagging on, especially when we're unsure of our replenishment rate. The best DIY mask that comes up is the Olson mask. You can just Google Olson. I would look at the Utah hospital. I think it's something Utah. I'm not sure if it's the hospital in Utah or the university. It is a washable, reusable mask. So it's like a cloth envelope. That's a bit tedious to make, but it looks very well made. And some people who I know who are from the military and defense research had their kids actually make it and said it's actually quite a well-made mask and would be definitely provide some protection. The filtering that you put in this cloth envelope is that I think they recommend a HEPA filter bag from a vacuum. The other things that you can use are furnace filter papers. So you can I won't name any brands, but different brands, they go on your on your furnace to filter out mostly dust, but surprisingly, most of these products actually were created to filter out dust. And so they definitely filter down to airborne level. So I think if you were in a country where which seems to be everywhere now, I think everybody should seriously look at that DIY. It's just, if you don't get replenished, and it's better to have something on hand than nothing, or wait until you're really down to nothing and find out, wow, I really wish I had done that. The other interesting thing that's come up above, and it is going to contribute to the burn rate, and what we haven't seen happen yet in many emergencies, it is now sort of recognized that in addition to social distancing, that the wearing of a mask by the public is protective, mainly because most of them, or not most of them, some of them could be asymptomatic carriers at this point when they present, and prevent really transmission. But now they're coming to our emergency department. Are we giving everybody masks that present without a mask? And I think that's not happening. But if we are not doing that, really we're falling below standard of public control measures. And in our emergency departments, which are less crowded now because of the fear of coming to the emergency department, I don't think that our chairs are set up in general to be 2 meters apart. So we really need to think about that. If we're having patients come to our emergency department, some of them may be asymptomatic transmitters, what are we doing to prevent them from transmitting, and secondly, from potentially getting it from people who are still waiting in our department, although most of us are able to get the coffers into some isolated space, but if it should get busy, there might be a delay on that. So I think we have to think about providing masks in our emergency department and what that is going to do to our burn rate. For non-PPE measures, some of the questions that get sent to me are, if you think about barriers and personal protection being a form of protection and safety, what are we doing for our staff who are taking lunch breaks? And I can tell you that I have not heard of anybody changing too much, and maybe they are, but the Chinese set up a communal lunchroom where everybody sat one person to a table. They were 2 meters apart. The table was immediately cleaned afterwards. I can tell you just from our own experience that that's not happening. We have a very small lunchroom. People may have just been in the COVID assessment center and then, are coming for lunch, and we're all there without our masks on. And how safe is that? And I think that probably everybody needs to ask again their infection prevention and control people. How are we going to protect each other from transmitting the disease? We're exposed to that because we're assessing these patients. We may not have symptoms. That doesn't mean we can't transmit it. How are we going to deal with this? Because as the numbers go higher, that is definitely going to be a threat, and that could be a potential very much of a sort of a place where transmission occurs between healthcare providers. And I think that is if I was going to put something high on the list to address, besides putting masks on people who come to the emergency, you better sort out your eating space. Some other things that may be not everybody's experience, but there's still a lot of people who don't treat this as a serious threat. And even though they have PPE, they don't wear it. So their masks are on their chin or on their desks, or they're eating or drinking in patient care areas. And particularly I'm talking about the emergency department where people will come to be assessed. How do you deal with that? You can tell them so many times to put their masks on, but at what point does it become an ethical responsibility for them to do so, and how do you enforce that? And lastly, this is sort of, I think, a topic that will become a topic of its own is CPR an aerosol generating thing? In fact, most guidance say CPR is not aerosol generating, but if you think about it, in fact it is. You are doing intubation, or you may be doing a BVM sort of procedure. So I think to think of CPR being labeled or described as non-aerosol generating, people should take care. And they really still need to control that airway. And anybody who's in that room that is performing CPR needs to have an N95 with them or on them, and the team inside needs to as well. I know there's talk about somebody finding someone VSA in a room and starting CPR. I'm not sure if just the CPR alone may not generate aerosols, but at minimum they should cover that airway with a surgical mask or immediately go out. And how long does it really take to put an N95 on? Not at all. You could even have one in your pocket if for unexpected things like that, so that you can put it on and activate the code. You can cover the mouth, and you can maybe with a mask or a towel or whatever and start CPR, and when the next person comes in, they take over the airway and secure the airway to truly protect the team. So I think that's my sort of update. So I'll hand it back to you, Eddie.
There's just one quick question from the audience, Dr. Mazurik.
Okay.
Could you speak to the evidence regarding heat treatment of N95 masks and other ways of sterilizing them for reusing them, UV, etc.?
Yeah, I'd have to pull it up, but if you go to Stanford, and if you go look online at Stanford and the University of Manitoba, you can find all the details that explain that in better detail that I can without looking at it directly. So I would definitely recommend looking at those. I think in Manitoba, they're talking about autoclaving, and in the hospital, they're also talking, I think, that you could do it using a pressure cooker. I don't have the actual link right in front of me, and they looked at treating a mask 10 times and not finding a degradation. They didn't use the actual coronavirus. I think they used another virus, but they felt that the sensitivity to the heat for this virus would be the same as the coronavirus. And so they felt it was an acceptable model. So evidence is always clearly something that we need to look at for sure. And I would advise people to take a look at those two sites themselves and sort of make up their own mind as to whether they think the evidence is strong enough to advocate for doing that. I will say that at our hospital, it seems now we are collecting the N95s, and I think it is with a view to determine whether they can be heat treated and then reuse. Again, my own personal thing is I kind of want my own mask back. I don't really want to use somebody else's mask, and I'm not sure why that is. It's just the thought of reusing somebody else's mask doesn't quite psychologically fit with me. That doesn't mean it isn't appropriate, but that's just how I feel. I don't know if that answers it or not, other than check out the sites, the links, which we can provide for sure.
Thank you. Before we move on to Dr. Henderson talking about the role of vulnerable clinicians, any other panelists have anything they want to mention for PPE?
Yeah, this is Dr. Saruna here. I think it's an interesting topic to discuss, especially for a developing country like ours. We did a quick survey around emergency departments in India just to find out what's their PPE burn rate. It looks like every department has used about 450 to 500 PPEs before they hit the first case, right? So we haven't seen the surge yet. So, but we are heavily using PPEs now. The concern is once the surge hits us, will we have adequate PPEs? So that's a question mark. But one advantage being in India is we are manufacturing a lot of PPE innovations going on as well, right from 3D printing masks and a lot of PPE manufacturing. But what's going to be key in the future is how we are going to read these and what would be the protocol. As the previous panelist rightly mentioned, the 3MS clearly in their guidelines, they said they don't recommend the N95s to be sterilized. But however, we need to find a guidelines for a country like us. We are trying few interesting things like UV sterilizing and things like that by using the dental equipment sterilizers and things like that, but we don't know the efficacy of it yet. So a strong guidelines or recommendation in this would definitely help for a country like India. Thanks.
Yeah, so I just a quick comment, definitely check out those links, and 3M really they are not in a position to approve this because they have made these masks with the clear indication they're single use. So for them to do anything other than that would really be against, I'm sure every lawyer in their team has said, don't do it. Let somebody else take the responsibility. So I think that other people have. The one thing that other countries, if you can think about elastomeric, half-face elastomeric PPE, so generally used in industry, like if for sanding or dust or whatever, those are washable, reusable, the filters are cleanable. They're not the most comfortable things to wear, but certainly they are effective, and to look into those types of things. People may not consider them initially because they don't think of them as being used in a medical sense, and we don't use them there, but they would be very effective forms of respiratory PPE. So look at your construction industry, your renovation industry, those types of things for the elastomeric half-face piece respirators, they would be effective and reusable. Had we thought about it, I think sooner in North America, we might have been able to get at least a certain amount of supply. They don't have a burn rate, right? Because they are reusable. They would be single, like individual assignment and sort of cleaning. So if you have the opportunity to look, I would definitely look in that direction too as well. And I do think the DIY in countries where your supply is either not there or may not be there, I would look at that DIY from just Google Olsen mask on YouTube and look for the one that's put up by Utah. I've had, like I said, I've had mask experts take a look at it, and they feel that it actually would be a good alternative when you run out.
Laurie, can I just come back? Thank you very much for that. Just a very quick comment about meals and staff rooms. One of our senior nurses very early in the outbreak got some hard plastic sheeting to put between small tables, you know, so a vertical split so that people could eat on both sides of the table. And subsequently, he's managed to get a custom built one for the long table that's in our staff room that divides it into 8 spaces. And this is about 2.5 feet tall. And it means that when someone coughs or chokes or, you know, just eats, you don't have the spray going across the next person on the other side of the table. And I think you're absolutely right. We have to think of innovative ways to keep people together from a wellness and a morale perspective, but without the high risk of cross-contamination during food.
Definitely.
I'm going to just add one thing as well, if anyone can hear me, it's very easy for access to PPE to become an unbelievably dominant conversation. And it becomes all-consuming for clinical leaders, both in departments and at national level, just talking about PPE. But what was mentioned by Laurie, which is so important, is how you wear what PPE you've got, and how you do the hand washing, and how you have access to water, and how you have gel, if you've got alcohol gel, in the right places so that you don't go through doors and then find it. Because people can become very angry. Healthcare professionals can become very angry about their access to PPE, but at the same time, not taking the basic things of, you know, washing their hands before they sit down to have lunch. And so we need to just be very careful that we don't get distracted by the kit from some of the really basic stuff, which actually some other countries may find as their main protective mechanism if they're actually doing the proper sanitation side of you know, public health protection.
One thing I actually forgot to mention, and it's a sad thing, but you should be aware of it. Theft of PPE has become an increasing issue. So wherever you do have your PPE, it should now be secure or under the watchful guidance of somebody, whether it's a security camera or something, because it's an unfortunate byproduct when there's not enough things that people decide that they are more entitled to than others, and it's a bit of a problem and contributes to the burn rate.
Thank you, everyone. Just for the sake of time, Dr. Henderson, can you take us to the next slide and review the role of vulnerable clinicians during the pandemic?
Thank you. So this will just be quick, but it's something that we need to consider. It's obviously we're putting people in the front line, we're putting people in the way of danger. And we have amongst us colleagues who have healthcare issues that we don't necessarily know about, and we shouldn't assume that we do know about. But we know that, unfortunately, this is a problem that is affecting older people, and it's affecting men more than women. So there really is an idea that you need to look at the profile of your department and see who it is that would come under the high risk group and protect them. And some of that is going to be the full shielding that we've done in the UK, where people are actually going to be away from work for 12 weeks. But some of it is actually just making sure that somebody is not working in your hot respiratory area, they're working in your lowest risk area possibly, or they are coming into the hospital, but they're not doing frontline patient facing work. So it's really important to be able to have an open conversation as a lead in your department, identify who's most at risk. Now, it's not completely even across a country like the UK, for example, as to which departments will have the highest risk staff. And it's quite important for us to recognize that. So if you're in a big urban center, you tend to have younger nurses and younger doctors. If you're in a rural, or for us, coastal town, you'll find that you've got a very stable EM staff population. And very often you'll find that you've got older nurses and older doctors working in those settings. And you will find that you've got the potential for losing a lot of staff. So you need to start thinking about it early. Think about the redeployment that goes on in your hospital, your organization, so that your frontline can be staffed by people who are not at a higher risk, and then identify the young staff amongst them who've got other conditions that put them at risk. So it's got to be something that's thought about. We've all got a duty of care to our colleagues, and we really got to make sure that we minimize their risks as much as possible.
Any follow-ups here from any of the panelists?
Yeah, I would just like to add something to this. I think India has done quite well in this regard with two things. One, there's a clear guidelines which says anybody above 60 years should not be posted in frontline, both in ER as well as in ICU. And two, the Indian government has introduced a special insurance package for the frontline doctors who are involved in COVID care. Now, anybody falls ill, they'll be treated free, and closer to about $3,000 are given for the treatment. And in case, God forbid, somebody passes away, about 50 lakhs or $70,000 is the compensation. So basically, they have introduced a special insurance package for those in the front line. Thanks.
Maybe you could share that with the rest of us so we can see the guidelines.
I will, yes.
I see. Dr. Henderson, could you also view this recommendation?
Yeah, sure. So
population?
I think most health systems will be identifying some of their highest risk patients, which are most places will have a list, and certainly in the UK we have a large list, and about 1.5 million patients have been sent letters recognizing that they are at significant risk, and giving them advice about the social isolating that's going on. But there are other members of society that it sometimes is a little bit easy to forget, but actually are which it's also important to remember, and particularly if you've got big urban centers. If you see a patient who's homeless but doesn't need admission, but you think they have got COVID, you could be in a situation, if you're not somewhere like Hong Kong, which is still managing to admit everybody still, which we remotely can't do, of sending a homeless patient back out onto a pavement to self-isolate on a pavement, with nowhere that they can wash their hands. And that clearly is an impossible situation and very inappropriate. So we run the risk of not treating the most vulnerable in our societies in a way that we would think was appropriate. And so in the UK, we're beginning to look at getting hotel spaces for patients who are homeless, but it's taken a long time to get going, and it's still, frankly, in London, isn't satisfactory. So I think if you haven't yet hit your, your surge, you need to start thinking about that patient group. The other patient group that's particularly a concern to everybody and is anyone that has got residential nursing homes, residential care homes for elderly patients who are clearly very at risk. And we've already in the UK had one nursing home in Glasgow, and obviously there was in America, there was Seattle, where a nursing home got the infection and it just spread around everywhere. So we now have some guidance about how you deal with COVID positive patients within a nursing home, how you try and maintain infection control to prevent other residents getting the infection, and which residents will benefit from being moved to hospital, recognizing that in some nursing homes and in some conditions of the patients who are in those sorts of nursing homes, there is going to be no benefit available from the facilities of a secondary care facility. So we are being able to send subcutaneous IV fluid to nursing homes, which is something that somebody might benefit from, but not exposing them to the futile things that might happen in the secondary care environment. But incredibly important to think about what's the patient mix, how you're going to preemptively help staff in a nursing home or in a hostel deal with what is likely to be coming their way. And in addition, think about patients who are in mental health organizations, and again, how you're going to manage that problem where it may be extremely difficult to maintain social distancing, and how do you keep the staff safe as well?
Catherine, it's we've also had a similar situation here in Canada. We've had one nursing home with 19 deaths. Unfortunately, there's very few healthcare staff in any nursing home, and as they take sick leave or they're quarantined because of tests, the result is you often hire very inexperienced staff who don't know how to properly clean and how to properly isolate and how to properly wear equipment. And so it runs through the nursing home very quickly. What we're seeing in nursing homes is what we see during influenza season. If you're not vaccinated, the elderly die. And it seems, since we don't have a vaccination for this, that we would get the same result in nursing homes if we had no vaccination for influenza. We would lose tens of people from every nursing home every winter. In the general broader scheme of things, it seems better to leave them, as you say, in their facility, because it's not that we have much to offer them in terms of survival if they come to the hospital. And unfortunately, we've said before, the elderly, the infirm are the most at risk, and these nursing home situations are proving just that.
I think that's right, but I think it's a matter of going in early, preferably before a nursing home has had an episode, and providing them with support. So we've got systems of linking community geriatricians to nursing homes so that they can go in, review plans, talk to relatives. We had one nursing home where the community geriatrician spent 3 days going through, I think it was 128 patients, being able to have conversations with the staff about what to expect. Because I think if the staff are devoted to their patients very often, and empowering them with a bit of information and a bit of knowledge that they will get support, makes a big difference to how it may not change the outcome, but it may change the experience of the outcome for the people involved.
Recommendation number 5.
So when we take a look at the preservation of hospital capacity, we have, I'm going to give you an example locally. We have a system that monitors ICU bed capacity. And it was expressed about a week ago that there was 94% occupancy of ICU beds in the province. And that had a lot of physicians panicking, saying we don't have capacity, when in fact, our ICU capacity every week for the past 2 years has been above 95%. We run on the edge of a blade, on the edge of a sword. We are always over capacity. Unlike other countries, it turns out that people in low or middle income countries actually have greater capacity than the more advanced countries. What we are doing in Canada is we are creating additional ICU beds within our own hospital. The post-operative care area has now got extra beds in our hospital for ICU, simply because we've canceled our elective surgery. The bed situation in one of our wards has been changed so that one of our entire wards has been changed to an ICU setting. We are able to do that because I'm in a new hospital, and we were built according to SARS criteria because of our experience in 2003. So our hospital has every bed is a private room that recycles air and the needs required for SARS. But you do have to have capacity, because at some point you will hit the exponential rise in patients. We have already canceled elective surgeries. We have already decreased our clinics to the point that when I come to the hospital every day, our parking lots are essentially empty. We have tripled our own hospital ICU bed capacity for needs. And if you take a look at the United States experience and the Chinese experience, they're building additional hospitals within 3 or 4 days. They're setting up tents to hold patients outside hospitals. You have to be creative because of the need that's required. But this needs to be thought of before you hit the exponential part of the curve. We have also created beds for alternative levels of care. We have created, as Catherine has suggested, beds in hotels. We have 3 hotels in the area of Toronto specifically for the homeless who have a test for waiting for symptoms for a URI to make sure they're not COVID positive. We don't return them back to the streets. We have consideration of opening up other hotels for people who have minor symptoms so they don't go back home. Right now, hotels are a resource that anybody can use simply because most hotels are fairly empty. But these strategies have to be discussed, and things have to be planned for before you hit the exponential part of the curve, so it's a proactive situation rather than a reactive situation. Back to you.
Thank you. On a similar note, recommendation number 6 is about functional redesign. Dr. Lang is going to be running us through this one. And there were some conversations beforehand as well amongst the panel about a drop in ED visits. And I think this is a topic we'd explore on this slide as well.
Thank you, Arshia. What we're seeing is a remarkable international phenomenon whereby anywhere between 30 to 40% reduction in ED volumes is being witnessed. Now, some of this could be related to the public health measures, but a lot of it is simply fear of coming to the emergency department because of the risk of potentially contracting COVID-19 infection. This has led, we've discussed this before the conference call started, so I applaud the efforts of the Royal College of Emergency Medicine and the Australasian College, who have been very actively messaging the population about the importance of attending to medical conditions, because in fact we don't want things to get worse. On the other hand, this has created an opportunity to allow a little bit more ED capacity and more time perhaps to prepare for the surge that might occur in some settings. Overall, and I'll welcome input from the panel, the challenge in redesigning the function of the emergency department is to create dedicated areas that are for COVID patients, COVID suspected patients, and to the degree that it's possible, because it's not always clear, and there are the description of what's called a COVID chameleon or a COVID bomb, where a patient unsuspected of COVID comes into a space that is not necessarily treated as such. So the key things we've done in Calgary is to create narrow corridors of service to limit COVID exposure, and that both occurs at the level of, it starts at the pre-triage, where we identify patients who might be at risk, and carries all the way through into dedicated, recently refurbished and redesigned sections of the emergency department. I might turn things over to Dr. Masaryk at this point, if that's okay, Laurie, to see your thoughts on redesigning the emergency department for COVID.
Yeah, the Chinese are extremely clear on this, that you need to have separate COVID and non-COVID areas for a number of reasons. Now, they have resources that obviously most don't have. They dedicated hospitals to COVID, and their pre-hospital care took people there, and they transferred people there from other hospitals. One of the mistakes in Italy, they said immediately, was the distribution of COVID to multiple hospitals really crippled their healthcare system very quickly. So if you try to create a system where you have absolutely a separate, even if it's within your own hospital, a separate non-COVID treatment area and a COVID treatment area, no, like separate entrances, separate staff, separate PPE, separate criteria for being there. You create a non-COVID area where you could put your high-risk clinicians in. We all know that there is the asymptomatic carrier, where there's this, undifferentiated shortness of breath where you're unsure. It doesn't mean in the non-COVID area that you stop your personal protective practice. In fact, they're exactly the same. It's just that you are more likely to have the low-risk patient there. An asymptomatic transmitter is going to have a low viral load. If everybody who comes into your assessment area has a mask on, and you do even proper spacing when they're seated, the people who used to be in our emergency departments and truly did need care will return. Right now, we're seeing a lot of pronouncements at home because we're a base hospital. We're wondering are these COVID patients not being detected and then are dying at home, or are these patients that should have been coming but are too afraid are now dying at home? So I think that having this is a very big plus. You have, like I said, separate staff, completely separate. Nobody can go between these two areas, and for sure you're going to get some of these asymptomatic or unrecognized COVIDs there, but they're isolated. You try to isolate everybody as much as you can, and everybody gets a mask. At some point, we'll get rapid point of care testing, which we don't have yet, but it is coming apparently, where the tests are available and results within less than an hour. That's something downstream. We don't have it yet, but it's something to look forward to. The other side, the COVID piece, why does emergency have to own it is what I would like to know. You should be able to set up a COVID clinic that is staffed by family practice. You can hire residents. We have residents in Italy. Residents are being hired on contracts outside their fellowships or their residency programs to run the ICU and other parts of it. It can be shared by medicine, family practice, ICU, anesthesia, anybody who wants to post the jobs for this, nursing, and let them get it and let them get danger pay, screen them for risk. So if you are somebody with comorbidities, I ain't gonna hire you. If you're at a certain age, you're not gonna go there. But because the population is now confident, or at least a little bit more confident, that we're taking care not to mix COVIDs with COVIDs, COVIDs with non-COVIDs, that person with their chest pain will feel that they can come to the hospital. So I think the Chinese are absolutely right in separating these two things. We're absolutely well behind hindsight is 100%. We already have the hindsight of the Chinese. We're getting the hindsight of the Italians. Why are we trying to de novo make our own experiences so we can have our own hindsight when we have clear evidence, or at least clear guidance to start creating these very separate things and thinking clearly about the staffing model? There's a lot of people who are young and healthy who are not working because their clinics are not going, or some parts of their going. They could easily work in a COVID clinic because there's not a lot of skill there, to be honest. And you're testing and you're giving them oxygen. And if you have an internist there, they can do a consult like anything else. So I think emergency medicine needs to divest the ownership of that piece and be a partner with everybody else in running the COVID side of it. And I completely agree about the triage being actually outside the hospital and everybody screened before they come in so that they're directed in the right direction. And the Chinese also have a one-way path. So when you enter, wherever you go out, you don't go back the same pathway, you go at a different pathway. So it's a one-way sort of direction. These are very simple principles. You would think And who could apply it? Well, I haven't seen any application of it in the depth I've described, certainly in Canada. I couldn't comment about elsewhere. I will tell you that we have First Nations or Indigenous populations with small nursing stations. They are able to do it. So if they can do it with virtually no resources, I certainly think we can start to think about how to do that when we have more resources, and especially when we have a great number of people not very actively doing anything, losing income, who might be quite happy to work in one of these things, and we then gives us the opportunity to again get the return of the people with the non-COVID disease and protect our at-risk clinicians. And there's a lot of us, so, and I include myself in that. And we should give them opportunity to create this system. It takes a little more initiative to do it, but we still have time, most of us. But if we do wait, I think we're going to get burned, and we shouldn't wait.
Thanks, Dr. Mazurek. Can I ask Dr. Henderson to address the pediatric dimensions?
So the drop-off in children coming to hospital is one of the areas that we're most concerned. Given that children actually seem to do pretty well from this, it would be absolutely heartbreaking if children are coming to harm because of delayed presentations of the things that affect children, like meningococcal septicemia or a perforated appendix, which would be something we just shouldn't see these days. So amongst your complete separation and functional redesign is separating your children's area as far away from your adult area as you physically can within the limitations of your facility, and making sure that they come and are managed in exactly the same way as you would have been previously, and that we get the message out to parents not to delay, not to self-isolate a feverish child who seems ill as opposed to not ill. Bring them in and get them checked out, because we're already beginning to see delays and late presentations of children who just shouldn't be coming to harm in this situation. So a redesign of that sort, very, very important. In general, if at all possible, having a totally separated area, but I completely support, and we fought long and hard to say, particularly an elderly person who comes in, who's maybe had a fall, who's off their feet, not eating and drinking so well, that's COVID until proved otherwise. So they may have ended up in your low risk area, but that's why your staff need to be wearing PPE. Back to you.
Great, thank you, Dr. Henderson. I think we can move to the next topic, perhaps. In fact, I think this actually was covered to a large extent by some of the recent comments and concepts of redeployment and sharing risk across various sections of the hospital. Maybe we can flip to the final topic, which is the palliative care considerations, and I would ask Dr. Ducharme to lead that discussion.
Thanks, Eddie. This is an increasingly important topic as the numbers in your country increase. I have to give credit to the provincial government where I work, here in Ontario and Canada. They have come forward with a triage guideline where they have made an ethical document that says, based on certain conditions, there's a triage level 1 where people with less than a 20% chance of survival should not be intubated and not have CPR. And then there's a triage level 2 where it's 50% chance of survival, and a triage level 3 where there's a 30% chance of survival. Hopefully we'll never get to the last one. But what this does is it provides a 24-hour-a-day availability for discussion with family members. It also gives a background document and system support for physicians on the front line making decisions if there's a lack of resources available. We've already sort of started this because, as we talked earlier, and Catherine mentioned this, in nursing homes, we're keeping people in the nursing homes and having them go through their COVID infection and often dying without bringing them to the hospital. There has been a lot of discussion around this to get this out as quickly as possible, even though we haven't yet gotten to it. We have to understand that not offering intubation or ventilation because of lack of equipment is part of any disaster code orange policy. There are triage level black patients that you do not treat even though they're still alive, because it prevents you from doing the greater good, which is helping as many people as possible. There are situations, for example, that we've already agreed in our hospital that you do not continue CPR on someone who comes in without vital signs, having had CPR started in the field with the paramedics. There needs to be an understanding, however, that the fact that you're not offering a ventilator to somebody does not mean you're not providing care for them. You can give them palliative care, you can give them supportive care. For example, we had a 90-year-old lady come in just yesterday in pulmonary edema. We can't use BiPAP because of the aerosolization of possibility, and our phrase is every patient is COVID positive. We treat everybody as if they're COVID positive. So we do not use BiPAP on any patients anymore. But instead of BiPAP or intubation, we started the patient on IV nitro, we gave the patient ACE inhibitors, we gave the patient diuretics, and 2 hours later, the patient was perfectly well. So the fact that we are not providing certain resuscitation services based on triage level criteria, based on ethical discussion and support, does not mean we still cannot treat patients. I would encourage everybody to have such discussions in your systems so that there are backing documents to give you a chance to discuss it, to have people available 24 hours a day, discuss it with families if they have a bit more time. As for CPR, we have to remember in COVID positive patients that the #1 reason for cardiac arrest is not respiratory failure. It is cardiomyopathy, and that people, when they die, usually have an ejection fraction of less than 10%. They are not salvageable. The question of who gets CPR in your emergency department should be someone probably reserved only to someone who's had cardiac symptoms and happens to arrest in front of you. People who come from the streets, we believe, should not have CPR. But again, you can't make those decisions independently. We have been fortunate that our province has given us a guideline with ethical support. And we encourage everyone to have those discussions to make sure that you have a set of plans in place so that you can bring them to discuss with family members. Eddie?
Thanks very much, Dr. Sharm. That brings us to the end of our webinar today. I want to thank a big thank you to all of the panelists for joining us. We would have a few minutes for question and answer, and actually the first one that's come to me via Twitter actually is for Dr. Ducharme, and it's about whether there could be consideration of IFEM providing resources to members to help guide clinical care. And we've discussed some of the resources available today. Would IFEM be willing, if I understand Dr. Mulligan's question correctly, to be something of a clearinghouse for these resources?
We're trying to do that as much as possible. We have on our website this, as you know, Eddie, this document. We also have several links to websites, and we are happy to be a repository for more that can be cleared and made available as a central location. We've interacted a lot with China. We've had Paul Ho, who's from Hong Kong, and a friend of Colin's, work very carefully to bring a bunch of documents together for the website. So we're trying to do that as much as we can. Clearly, we can't have every document, but if people on the panel or people on this discussion want to send further documents to our head office, we are happy to post them on the website.
Thanks, Jim. Before we close, are there any final comments that people would like to make?
Yeah, Dr. Saruna here. Just wanted to bring about 2 points here. So one is the weakest link in the entire chain, the EMS personnel, the ambulance drivers, and of course the housekeeping personnel who manage some of our critical units. So clearly we are having problems in providing PPEs and supplies to them and keeping them safer. So I think that's going to be one of the areas where developing systems have to look at. And also we are beginning to see this resistance from the residents across, not just emergency medicine, but in other specialties as well, who are actually refusing to turn up because of this fear factor. Right. So because of a lot of videos and things which are being shared in social media on how doctors are getting affected throughout the world. So I think this is something which might cause some problems in the future. I don't know whether any other country is facing similar situation across. I would like to hear from anyone who has a similar situation.
Saravana, what we're facing, because I know Catherine brought up hiring all these young people to work in COVID clinics. The problem is, I would say in Toronto alone, 80% of family physicians have closed their offices because they don't have the ability to provide PPE and keep their offices clean. And so they're just refusing to take any risk. So it's astonishing, you know, we've all bought about the fact that there's way fewer patients in emergency departments due to fear and what that means in terms of risk to people. I saw a lady yesterday who was diabetic who had a terrible abscess. She'd waited way too long because of fear coming to the emergency department. But not only are they afraid to come to the emergency department, they don't have another resource. Dentists have closed their offices. Family physicians have closed their offices. So they're not only not able to come to the emergency department out of fear, they don't have anywhere else to go. And I just don't know what's happening to all these patients who've been using the system routinely and now have nowhere to turn. I certainly know I'm seeing way more dental patients in the past few weeks than I'd ever had in my career. So, Lori, you're aware of this as much as I am. I just don't know what's happening to all these patients and what they're keeping at home, what they're not doing.
Well, I think for sure they're staying home out of fear. And I think they have a good reason to be afraid, because where are the COVID patients? They're coming to the emergency department. I often joke, if you want to catch something infectious, just come sit in our waiting room. It's a sad fact that I think is actually truthful. So that's, I think, the reason we really need to establish the COVID, non-COVID sides and clearly separate them, knowing that the, the asymptomatic COVID patient will sneak in on the non-COVID side, but there'll still be a lower risk to people. And if we don't do this, we're going to have a greater death rate that's not recorded as a COVID death. And that's the non-COVID deaths that people that die or suffer significant mortality or morbidity as a result of disrupted care. And in fact, most disasters or even war zones, it's the disruption of the care that kills more people than say getting shot by a bullet in a war zone. So I think we have an elderly population, we have a population that may be even younger with significant comorbidities. We need to reopen and say that we are available to care, but they have to have proof and evidence that we're actually taking the precautions necessary to keep them safe if they come. At this point, I don't think we are. It's the next step we need to take.
Can I just add a comment about another patient group? Because somebody asked a question about malnutrition, and the only malnourished patients that we're really seeing are the homeless, and they're being hit hard and they need protecting. But the other end of the malnourished, unfortunately, is diabetes and obesity. Diabetes patients are doing extremely badly. We're seeing patients who are presenting in a ketotic state. So they're type 2 diabetics, but they're presenting in ketosis. And they're getting ketotic so quickly that sometimes the pH is maintained, but their bicarbonate is through the floor. We've seen first presentations of DKA, and we've seen hyperosmolar. And then there's a lot of discussion about fluid management of coronavirus patients. And it looks like maybe at the beginning we were running people too dry, but it might be that the diabetic patients are ones where the early boluses need to not be quite as high, balancing the AKI risk that we're all seeing amongst these patients. So obesity, for a number of reasons, including the difficulty of your airway at the point of intubation, but combined, and presumably how difficult it is to be ventilated in the sort of illness that we're seeing, combined with diabetes, it does seem to be a particularly difficult group, and it's diabetics who are the kind of the unremarkable spectrum of metabolic syndrome, type 2 diabetics who actually have never really come to anybody's attention particularly, and maybe are just being managed on diet, who seem to be presenting in a problematic way and ending up on our ICUs.
Well, thank you, everyone. This has been a fascinating discussion. I really want to thank all of our panelists, from Dr. Ali, Dr. Graham, Dr. Henderson, Dr. Mazurek, Dr. Sharm, and I hope I didn't forget anybody. Also, a huge thank you to Arsha Javidan from Toronto, who is keeping us all organized. Aaron Peterson from the Physician Learning Program, who has kindly agreed to edit this presentation for the pauses and provide it as a link in a YouTube video that will be made available around the world. Thank you for all of your questions and for joining us. And we wish you the best of health, well-being to you and your families in this difficult time. Thanks, everybody.
Bye-bye.
Thank you.
Thank you.